how you are managing the radiological investigations in these patients.
Sure.
Are you doing only X-rays? Because getting them out of the ICU to a radiological suite would be obviously difficult, as well as it will increase the spread. So how you are managing lung ultrasound and X-rays only, which can be done on the bedside, avoiding CT scans.
Absolutely. So it's a very important topic in the sense that we have to prioritize and ration the amount of imaging that we do for these patients. So you cannot do as many CT scans or X-rays that you do for other patients. What we are doing so far is that we are limiting the number of X-rays. We do one on admission and one if a clinical situation changes. And if someone is trained in ultrasound, use ultrasound instead of using X-rays or CT scans. And once you know that this is a COVID positive patient, then doing a CT scan purely for the sake of it is not necessary unless there is a specific need for that. For example, you can think of if there is a pneumothorax one is not sure about and so on. But what's been described so far, and I certainly have scanned quite some patients, is that ultrasound is good enough in a way. If you do it regularly, you can look at the B lines, you can see if there is a particular collapsed lung segment, you can see if there is a pleural effusion developing, which is not a major problem in these patients anyway. So I would say that if possible, if there is expertise available, then ultrasound can be your friend. And CT scans regularly, certainly, definitely, I wouldn't do it, and I know that not many people are doing it because not necessary. One caveat is that when you are treating COVID-19 patients, you will have other pathologies coming in, masquerading as COVID, and those patients have to be identified quickly. And sometimes they need a HRCT. And if you have a diagnostic uncertainty, look, this may be an inflammatory pneumonitis or some other pathology is going on, and your initial test is negative, then with all precautions, CT is warranted and should be done to clarifying the diagnosis, because all other diseases are not going to wait until COVID is over. They will keep happening, and we should not treat all of them as if they're COVID. That's a very important thing. Sometimes you get mainly the CTILD, connective tissue disease.
So you are saying,
etc. They may be COVID, they may be something
when
else. You need to differentiate.
you are conclusively proven or ruled COVID out, then only you are sending patients to CT scan out of ICUs. But if the patient is a COVID positive, you are trying to manage for all practicality.
Yeah, or if you are not sure that COVID, this could be a different disease.
Right.
When you need to
establish
a diagnosis and CT will help, you may do it.
Right.
But it's purely a COVID.
So, is there only one test being done, both as a screening and confirmatory test, or NHS is using a rapid screening as well as a more robust confirmatory test?
NHS is a public sector widespread organization, and one has to kind of look at the cost effectiveness and practicality of what happens, how you provide a test. And what's happening right now is that only throat and nasal swabs are being sent for RT-PCR, and they come back for ICU patients very quickly. If they're in the ward, it takes some more time. Say what you have seen is it can take up to three days or something like that. But for ICU patients, we are getting the results within the next day. And if the first test is negative and your suspicion is high, we are sending a second sample. And we are trying not to do a BAL for these patients right now. We have talked about a non-invasive BAL, NBAL, and deep tracheal aspirate. Those are things that can be done. But BAL sensitivity is about 90 to 93%. And between throat and nasal swab, sensitivity is about 75%. So if you rely on just throat swab, it's about 62%. So the first time, if you get the result positive, 1 in 3, 1 in 4 might be false negative.
So when are you
1 in 4 might
repeating?
be false negative.
At what interval
Therefore,
you are
if
repeating?
If you really think this patient has
After
it,
how long you are
repeat,
repeating?
and you increase your chances of capturing the disease. BAL we are not doing at the moment.
What is the scientific
As soon as
basis
the
of
result is back as
having false
negative, but
negatives?
we feel
Is
that the
it
patient
the low
is
grade of
positive, we are
viremia
repeating it.
or improper sampling?
I can't give you an exact answer to that, but that's what has been seen so far. The Chinese data has shown that between throat and nasal swab, 75% sensitivity. So it might be the initial viral load. It might be
Any news on the
assay
card test?
I'm not a
Very
virologist.
quick card test which can give you in minutes.
We are hearing about that. It's not there yet. We are hearing rapid bedside diagnostics. It's not here yet. The other thing that might come soon is the IgM and IgG testing, and again that's not here yet. If that comes at some point, that will be really helpful because you can quickly screen not only patients but also healthcare staff, because anxiety among healthcare staff is very high. Therefore, if you can
Okay, how what are the typical your
and you are well,
investigations that are coming back for a COVID positive patients? How does it look? Because we came to know a lot of lymphopenia is happening, the ferritins are up, the NLR is, the procalcitonin is surprisingly unequally low. So can you please elaborate a little bit on the investigations that are typically being found?
True. Lymphopenia is 100%. In all patients, we have seen lymphopenia so far.
Unless there is a secondary
PCT is normal, completely normal, and it is remaining normal for nearly a week. It might be just about mildly raised, and PCT should be done repeatedly to. Yeah, but that's not a regular. That's not something we are seeing. That's not something we are seeing really. And PCT should be done regularly to capture secondary bacterial infection or BAP so that it can be treated quickly. We certainly have patients where they have not been on any antibiotic for the whole week and PCT is normal. And CRP is high in the region of 150, 200, thereabouts. Ferritin is high in most patients in the region of 15, 1600, 2000. Surprisingly, people who are not doing well, ferritin could be normal. And that's something we need to explore exactly what is the explanation for that. Then what we are also seeing is that some patients are coming to hospital with very mild AKI, AKI stage 1 and something like that. I think most likely because they're hyperventilating, they're tachypnic, so they're a bit dehydrated, and as soon as they come to ICU, when they start to get ventilated, eventually that settles down. No one is hugely in kidney injury. Some people might have a little bit of liver derangement, but not much. And troponin has been discussed quite a lot, and all the patients that we have done, troponin has been normal, other than one patient, one or two, where there have been some previous cardiac history. But again, that troponin is not that high. So every hospital should probably follow a pattern of what tests they do on upfront and what are the tests that help to prognosticate. The other thing is D-dimer. D-dimer has been shown to be high in many patients. That again is one can decide whether they are doing it or not. But definitely, ferritin is a very interesting one in this whole picture.
I'll come to that part.
No, not much
on the next question.
It is presenting purely as a single organ.
Besides, we are all aware that it is eating up the lungs,
with a bit of
damaging the lungs most. So, what are the other organ dysfunctions that you are seeing?
There are two parts to the answer. One is that in the wider literature, as you all know, there is a group of people who are showing cardiomyopathy. But in patients we have seen or colleagues in other hospitals that we have spoken to, this cardiomyopathy part we are not really seeing that much yet. Maybe it comes at a later stage. And I certainly have echoed at the bedside or troponin. We are not seeing much cardiac complication of this. Kidneys, not a great deal of problem unless you want to very aggressively dry them out. If you want to diurese them hard enough, whether that then has an impact, possibly, but usually it's not showing in the primary stages any particular kidney insult. Liver, I said, very mild in some patients. Coagulation, not hematological, not much of a problem. Gut, lots of these patients are not going into ileus or gastroparesis. They are absorbing the enteral feed pretty well. And neurologically, obviously, there is nothing much to. They're deeply sedated
As
or
of
paralyzed
now,
also.
so unless it
Essentially,
changes its
it is behaving as a
characteristics,
single organ
unless
failure,
it
at
mutates
least in
and
the
changes
first
characteristics.
7